This video will cover the present recommendations for supportive care of COVID-19. Conditions continue to rapidly evolve, and this will be one of many updates. I will also be sharing these video updates on Twitter at FS Southwick, as well as in LinkedIn and Facebook. As discussed in the pathogenesis video, SARS-CoV-2 has a high affinity for the ACE2 receptor of the airway epithelial cell and quickly spreads to the bronchi and alveoli, where it causes inflammation and fluid accumulation, resulting in a ground glass infiltrates in the lungs on CT scan and a decreased ability to exchange oxygen from the alveoli into the arterioles. Patients with mild to moderate disease who don't require oxygen supplementation can usually be closely monitored at home to reduce the spread of infection in the hospital. However, the clinical signs and symptoms may worsen as the virus spreads to the lower respiratory tract. If you suspect you have contracted the virus, it is important for you to call your local COVID-19 hotline because each case will be different. Decisions on triage are best managed by a healthcare professional. Conditions that may be associated with worsening include older age, chronic health conditions, or an immunocompromised state. Significant shortness of breath is a warning sign and may warrant hospitalization. I want to emphasize that despite significant reductions in oxygen saturation below 90%, a significant number of hypoxic patients do not experience shortness of breath at rest. This is because early in the infection, there are no changes in lung compliance. Compliance being defined as the change in lung volume divided by pressure. Many infections reduce compliance of the lungs. That is, it takes higher pressure to expand the lungs, and this reduction in compliance creates a sense of shortness of breath. Also, COVID-19 lung infection is rarely accompanied by an elevated carbon dioxide or CO2. Elevation in CO2 in the blood is normally the primary signal associated with shortness of breath. Recognizing this reality, many health systems are now encouraging homebound COVID-19 patients to use electronic oxygen saturation finger monitors to follow their oxygen saturation several times per day. These digital monitors can be purchased for $30 to $40 online and run on AAA batteries. And I just purchased one. If an infected patient discovers that their O2 saturation is consistently below 92, they should contact their healthcare provider immediately. This guideline would not apply to patients with significant chronic lung disease. Most patients with chronic lung disease should be admitted to the hospital if they acquire SARS-CoV-2 because of their increased risk of complications and death. The primary goal of supportive care is to maintain oxygenation to provide time for the patient's immune system to kill the virus. Nasal oxygen at 4 liters per minute is commonly required to maintain an adequate arterial oxygen saturation above 92%. Higher flow oxygen may be required as well as non-invasive positive pressure ventilation BiPAP. However, both of these treatments cause the virus to be released in an aerosol, fine particles that can be inhaled and invade the lungs of those caring for the patient. If oxygenation can't be maintained with nasal O2, experts recommend going directly to intubation and mechanical respirator. This approach provides more reliable positive end expiratory pressure, PEEP, and ventilation. If full-blown acute respiratory distress syndrome, ARDS, develops, the patient should be placed in the ICU. Lung-protecting ventilation settings with low volume and high respiratory rate should be used, and patients should be periodically placed in a prone position. Prone positioning, lying the patient on their stomach, prevents the largest area of lung from being compressed and causing alveolar collapse. I have personally seen dramatic improvements in oxygenation when the patients are placed in a prone position. Another feared complication of SARS-CoV-2 infection is cytokine storm, which can lead to a septic shock accompanied by organ failure, as described in the case I presented in the clinical presentation video. These patients should be managed using a standard sepsis protocol, including empiric antibiotics. Fluid management should be conservative, keeping in mind that these patients have fluid in their alveoli. I will share more details of how SARS-CoV-2 causes cytokine storm in the video on treatment with monoclonal antibodies directed against specific cytokines and the efficacy of corticosteroids for treatment of this condition. In addition to high flow oxygen and BiPAP, other activities that can lead to dangerous aerosolization are intubation, bronchoscopy, obtaining nasopharyngeal samples, and nebulizer respiratory treatments. It is important that everyone caring for the patient don personal protective equipment. A tight-fitting N95 mask or controlled air purified respirator capper should be used during any of these procedures. And always wear eye protection, gowns, and gloves. Face shields are becoming increasingly popular for assuring eye, nose, and mouth protection, and the hospitals in our hospital are now leaving them on for the entire shift. Cleaning at the end of each day with soap and water or a disinfectant. It is important to practice properly removing masks, gowns, and gloves so you don't inadvertently contaminate yourself. Avoid touching the outside surface of gowns and gloves or touching the front of a mask or face shield. You owe it to yourself and colleagues not to break sterility and become infected. We can't afford to lose anyone on the front lines. In summary, mild to moderate disease not requiring oxygen supplementation can be managed at home with close follow-up and monitoring with a pulse oximeter whenever possible. The primary supportive therapy is oxygen supplementation with nasal O2 or mechanical ventilation. In patients that develop acute respiratory distress syndrome, ARDS, low volume, rapid respiratory rates are recommended to reduce lung trauma, and prone positioning improves oxygenation. Cytokine storm can lead to hypotension and a sepsis syndrome. Fluid should be cautiously administered so as not to exacerbate fluid accumulation in the alveoli. Providers must wear PPE, including an N95 mask, when aerosol production is anticipated, and we emphasize the usefulness of facial shields. Thank you.